Welcome to the Peds Hub podcast. We are a group of paediatric trainees in the South West who every month review a selection of articles that we find useful for our practice. Please note, these are our own opinions and are produced for educational purposes only. They are not intended to substitute professional medical advice, diagnosis or treatment.
Thanks for listening.
Welcome to another episode of Peds Hub Pod. Today we're joined by Alicia, a paediatric registrar based in the South West, and we're going to be discussing neurodevelopmental care in the neonatal unit. So Alicia, I'd like to start by welcoming you to the podcast and asking you to tell us a little bit about your training journey and your interest in neurodevelopmental care.
Thanks for having me. So I'm Alicia, I'm a paediatric registrar and I've just been working at St Michael's neonatal unit for the past year, but I'm now working down in Truro just as the general paediatric reg. But I have always loved neonates and then have developed an interest in developmental care through mainly working on the Cuddle Bundle, which is a project to do with skin-to-skin care.
Awesome.
And also a little bit about exploring parents' views of ward rounds when I was at Jefferies Hospital.
Lovely.
Yeah.
Well, I look forward to hearing a little bit more about the Cuddle Bundle later in this episode. But perhaps a good place for us to start would be defining what we mean by neurodevelopmental care. So neurodevelopmental care, also known as developmental care, involves creating an environment that promotes optimal brain development in premature or critically ill newborns. This includes factors like minimising sensory stresses, fostering parent-infant bonding, and providing developmental support more generally. It's about creating an environment that mimics the womb as closely as possible. This includes controlling light and noise levels, promoting skin-to-skin contact, and ensuring proper nutrition and sleep cycles. The early weeks of life are a critical period for brain plasticity, making this care essential for long-term outcomes. And this is something we're going to cover more throughout this episode. So Alicia, I wonder if you could perhaps start by telling us how the early environment in the neonatal unit impacts the baby's development.
So I guess the early environment in the neonatal unit impacts baby's development hugely in lots of different ways, but just kind of go back to basics. So when a baby's born prematurely, all their senses are underdeveloped. So, and if a baby has sensory experiences which are inappropriate for their stage of development, then their neurodevelopment will occur differently than it would if they were still in the womb.
I see.
Also, we found that children that are born preterm are more likely to have learning and social communication difficulties later in life. And we've also found that there's a higher rate of autism spectrum disorder and ADHD in children born prematurely. So there is a link.
And are we defining preterms as those born before 37 weeks?
Yeah, that's right. Yeah, so preterm's any baby born before 37 weeks.
Fab, so it's especially important for that cohort of babies. Also.
Yeah, but all these things we're talking about can also be relevant to the term baby. So our poorly term babies, if they've got sepsis or HIE or a huge range of things that we see term babies come into the neonatal unit, it's all important for them.
So Alyssa, you mentioned that there are a number of different sensory systems that babies develop early on in the womb, but then affect their experiences from when they come into the world and their time on the neonatal unit. Can you tell us a little bit more about these?
So we all have our 8 sensory systems. We've got touch, movement, proprioception, smell, taste, hearing, vision, and interoception, which is all those inside feelings you've got, if you're nervous and you get butterflies in your belly. And the first one of these sensory systems to develop is our tactile sense, which develops really early on in utero. So this is our ability to sense touch, pain and temperature. So when babies are born premature, they will be able to understand touch, pain and temperature. And we have a lot of negative touch on the NICU, such as all our cannulas, heel pricks, NG tubes, intubations. It's just endless, isn't it?
And we often do many of those many times a day.
Yeah.
I mean, hopefully not intubating babies too many times a day, but many of the kind of like heel pricks is something that we do regularly.
Yeah.
And I suppose like even, think about glucose monitoring.
Yeah, exactly. The gases, if the baby's ventilated. And it's been found that all these negative stresses and negative painful procedures can lead to the baby having increased release of cortisol. And that can have an effect on the preterm baby as they grow older and into later life. So there's been research into post-traumatic stress disorder, and how babies, because of this increased cortisol release, they have a similar reaction to adults that have experienced PTSD, and it's a similar thing that babies have experienced PTSD in the NICU from these painful procedures and negative stresses. So it's really important that we're trying to encourage positive touch as well as the negative touch, because the negative things that we do, we have to do, because if a baby needs intubated, they need intubating. But it's ensuring that preterm babies are experiencing positive touch in the NICU to try and create those kind of like neurodevelopmental pathways in their brain, so they're not just associating touch with something negative.
I see, okay.
And so positive touch can be something like not just going into the incubator and picking up the baby's foot and doing a heel prick, but actually placing your hands on their head so that they know where you are, or talking to them as well. Using the parents if they can't come out for skin to skin, because you can do procedures like heel pricks, sometimes cannulas, whilst the baby is out having skin to skin or having a cuddle. But using hand hugs, so like getting the mum or dad to place their hand one over the baby's head and one over their bottom or on their legs, like in a flex position. And that's just a comforting, positive touch before you do the more stressful, painful procedure.
I see, so just trying to balance that out, just to try and reduce the response that you might get from cortisol, from the stress of it.
Yeah, exactly.
Okay. And is there anything about kind of the timings of which we do these and trying to do it all around cares?
Yes, so try not to wake them from sleep, but if they need to have a nappy change, then you could do your heel prick when they're having a nappy change. But equally being aware that if they've just had a cannula, maybe not then go and do a heel prick, a long line, an NG tube, because that's too stressful for the baby to have multiple things. And if me and you were having painful procedure after painful procedure, we wouldn't like it if they were all at the same time.
Absolutely.
Yeah. And then we've got our other sensory systems. So we've got the vestibular system, so how the baby processes movement. So a baby needs to learn to move, and they'll be doing that in the womb. So it's like when we go swimming and it's all a bit more free and you're not having to deal with gravity. So that's how a baby would learn to move. But if they're born preterm, they haven't got that. So to try and support this, we keep them in a flexed and contained position. And then babies are able to learn movement gradually. One of the really nice things of them learning movement is if they're out having skin to skin, they can learn up and down movement by being on mum or dad's chest and just the breathing movement on mum and dad.
The breathing pattern, it allows them to experience that.
Yeah, exactly. And along those lines is proprioception. So babies have got the receptors in their joints, and proprioception's knowing where our body is in space. So if we keep them in their arms, legs flexed, all cocooned, like they would be in a womb, that helps them to develop their proprioception from knowing where their joints are, and they're not all flailing around.
I see, and that's why we have the boundaries in, and then once they get to a certain age of gestation, we are able to remove those because they've developed, built those neural connections.
Yeah, exactly. Yeah, they know how to move their body, and also, they know their proprioception, so where they are in space. And then the other sensory systems, such as taste and smell, so they can develop this when they're in the womb. And so we can use breast milk and sucrose. Breast milk is really good. So if you've got breast milk, use over sucrose. But if you're doing something that's stressful to the baby, then trying to mitigate that with something that's sweet for them to taste. Smell, so babies are able to smell their parents, especially their mum. So trying to reduce deodorants or perfumes. And also talking to parents about, the baby can smell the mother's normal body odour, so she doesn't need to wear the perfume. So we can also talk and educate parents as well.
And again, something that we regularly do in Survives is give parents sort of little pieces of cotton materials that they can kind of wear with them when they're not with the baby, and then switch them over, just so there is that continual familiarity in the incubator. Yeah,
there's a really lovely the cotton wraps that they put down their tops, and then they get the nice smell of mum, and it's so lovely, and then they're in the incubator with them.
Absolutely.
Yeah, it's really, really nice. And then hearing, so babies are not able to process a lot of noise, so that's why it's really important to keep it quiet in the NICU. And you might see those big, the electronic ears that are up on the walls, and they kind of flash red if we're speaking too loudly. So it's important on ward rounds when there's so many people to try and keep it quiet, and also not have our conversations about random stuff by the baby's bed.
And that's something everyone on the unit can do that from day one, can't they?
Yeah, exactly. Yeah. And then vision. So if a baby, they don't need to use their eyes when they're inside the womb. So when they're born preterm, they're often exposed to light, which they're not ready to have. So making sure that you cover their eyes if you need to take the blanket off their incubator in order to do a procedure, and keeping the blanket back over the incubator and just trying to keep it dark as well. So everything is trying to just stimulate what it would be like if the baby was inside mum still.
I see. And again, I imagine that's why we have the eye covers when babies are being treated for jaundice with phototherapy, and just ensuring, I guess, those are in position, every time if you're examining a baby, keeping that protection of their visual stimulation.
Definitely. Yeah, exactly that.
Thank you so much for explaining the sensory systems, and I think it's just really nice to be extremely mindful every day. Babies have the same experiences that we do, and every interaction that we have with them on the neonatal unit, we're able to protect their developmental outcomes and the way they're experiencing the world. So I suppose one thing that I learned quite early on as an ST1 going into a tertiary neonatal unit, we had a wonderful talk at one of our inductions just about the ways in which we might be able to interpret how a baby is responding to the stimuli. And a really nice example that was shared with me was the idea that sometimes babies might put their hand up to say stop, or they're experiencing a lot of things. Are there other things that we can be thinking about, or other signs that we can pick up on?
Yeah, definitely. There's quite a few. If a baby's happy and they're ready for interaction, they sometimes you see them smiling, which is not always wind. They might be mouthing as well. They show that they have relaxed limbs, they just have a little bit of relaxed posture, maybe not really moving that much. Counter that if a baby's poorly, they also don't move. But if they're relaxed, not really movement, or they're smooth movements, they might be awake but not crying, just eyes are open, looking around, look comfortable, or having their hands to their face. Or sucking as well as another one, and they've got a flexed posture. So these are all cues that I'm a happy baby. And come and see me, maybe ready for interaction. That's compared to the I'm a stressed baby, I'm unhappy, I'm overstimulated, stop what you're doing. And that's, like you said, the stop hand, where they put the hand up in front of their face. And other things, they might have really stiff, straight legs compared to the nice flexed posture when they're happy. They might be having really frantic movements as well. You might see that if you're doing a painful procedure, and they might not cry, but they might be really straight arms, straight legs, frantically moving around. And that's a sign to maybe just pause what you're doing, maybe get the parent in to give a hand hug, maybe give some breast milk or some sucrose just to try and soothe that baby until they've de-stressed. Other things, they might hiccup, they might yawn, they might have a colour change, they look away. And then there's the facial grimace, which is probably an obvious one for us to pick up on. And if you've ever worked on NICU, they start having bradydesats, so they're dropping their heart rate and they're dropping their oxygen saturations. That's a definite, I'm not happy, stop what you're doing.
And I suppose some of those are quite subtle, aren't they? And it's probably challenging to balance the need of doing a procedure with picking up on these cues. So I guess it's just being mindful of them, just responding in the best way you can.
Yeah, exactly. And I think it's okay if we do need to do a long line if they need to have TPN, but you can pause during that long line and make sure, is this baby okay? Can I change something in what I'm doing to probably make me more successful in getting it in, but also to make the baby more happier, and like we were saying earlier, to reduce that stress response, reduce that cortisol, because it's all about their neurodevelopment and just trying to minimise all the stress that they have in the NICU.
Thank you so much for talking through some of those more subtle cues for us to look out for, Alicia. Are there any resources that you would recommend our listeners look at for some examples of these?
Yeah, my favourite one is Blooming Littles. So it's a website, and she also offers courses. She's an occupational therapist based in the States. She's got an awesome website, but there's also loads of nice blogs, and there's a poster about all the different cues to look out for in babies with pictures of what they look like. So I recommend looking on Blooming Littles.
But we'll try and put a link to that in the description of this episode.
There's also, with the South West Cuddle Bundle coming out, we're going to develop some cot cards which have got cues as well. And they're going to go by the cots of the beds.
Well, that's something definitely for everyone to look out for. So we know that early experiences have a profound impact on a child's brain development. Can you tell us a bit more about the science behind this?
So during the neonatal period, the brain is highly malleable and plastic. So our positive interactions, such as what we're talking about with the gentle touch and soothing sounds, help form your vital neural connections that can then affect cognitive, emotional and social development later in life. Contrast to that, if you've got prolonged toxic stresses, this can cause dysregulation of the hypothalamic pituitary adrenal axis, which can then lead to dysregulation of multiple body systems. So if a baby is exposed to stress, a preterm baby is exposed to stress, initially they have an exaggerated response where you might see their heart rate going up, they might have a desaturation in their oxygen levels, they have that cortisol release. But for a preterm baby that is having chronic stresses, this can then blunt their autonomic and their neuroendocrine responses, which leads to a reduced stress response. There's been quite a few studies investigating the effects of stress on preterm infants. Preterm infants who experience chronic pain from MRI scans have been found to have reduced white and grey matter maturation. They've also found that there has been epigenetic modifications which can affect your developmental outcomes and learning later in life, and it can also affect the next generation as well. So a study looking at rat pups investigated maternal behaviour and found that lower levels of positive maternal behaviour, responses to stress, were altered in the rodent pups through epigenetic mechanisms mediated by the HPA, so the hypothalamic pituitary adrenal axis, through the glucocorticoid receptor protein. This also can affect thyroid and serotonin signalling and can impact infants' ability to manage stress into adulthood. So another really interesting theory is by Porges in 2011, the polyvagal theory. So the theory is to do with evolution and where your vagal nucleus is in the brain. Mm-hmm. So in reptiles, their vagal nucleus is very posterior, so dorsal, and in response to fear, they go into a sit still, pretend to be dead response. Mm-hmm. This is compared to mammals who have developed their vagal nucleus is more ventral, and that's the fight or flight response to fear. And then we've come into mammals who are more socially interactive, such as us and apes, and they have a supravagal nucleus, which is even more ventral, and it links the vagal nerve, link it into your heart rate and your autonomic system, mm-hmm. and it links to the facial muscles as well. So when we see soft facial features or a soothing voice, such as a baby seeing their mother, it lowers their heart rate and lowers their oxygenation. So if a baby is out for skin to skin, having cuddles with their parent, their mum will be showing their soft facial features, speaking softly to the baby, and the baby will also be having soft facial features as well, in that nice relaxed positive position, being very comfortable. And that is also demonstrated by their autonomic response, which is showing mm-hmm. their heart rates reduced and their respiratory rates reduced, their oxygen levels are not as high as previous. When you then take the baby back into the incubator, the sympathetic fight or flight response is activated, and they have a surge of cortisol and catecholamines, and that's where you might see the baby starts to bradydesat, they drop their oxygen levels,
mm-hmm.
the heart rate goes up or down negatively, mm-hmm. down, and the baby may stretch their arms out and flail.
So again, it's just kind of highlighting the underlying mechanisms behind some of those cues that we talked about earlier, and the ways in which we might be able to support, whether it is the parents' soft voice, soft touch, to reduce the cortisol, reduce the fight or flight mm-hmm. response that they're experiencing.
And then interestingly, this is relevant to us when we're doing painful procedures mm-hmm. in our preterm babies, that, and as I was saying, when they experience chronic stress, it blunts that mm-hmm. response. Similarly, preterm babies, they can then regress to that reptile mm-hmm. vagal nucleus being more posterior, mm-hmm. and they go into this catatonic state. And it doesn't mean that they're okay having this cannula being put in. Mm-hmm. It's just that their sympathetic system has become too exhausted and they don't know what to do, so they've gone into this catatonic state.
I see. So we've spoken a little bit about some of the underlying mechanisms in response to negative stresses in the neonatal unit. I wonder if we could perhaps take this further and think a little bit more about that ongoing development and looking into the longer term effects. You've also previously mentioned about the epigenetic changes that we may see and how this can affect children later in their life.
So research indicates that babies who receive neurodevelopmental care have improved developmental scores, so better attention spans and lower instances of cognitive and behavioural issues as they grow. which links into us talking earlier about how preterm babies who maybe have not had as good a developmental care, there might be a link between autism and ADHD later in life, or just difficulty in social communication and interaction. So findings from the Newborn Individualized Developmental Care and Assessment Programme, NIDCAP for short, indicates that babies who receive developmental care have improved developmental scores, better attention spans and lower instances of cognitive and behavioural issues as they get older.
And that's interesting. We'll link to the NIDCAP programme in the resources as well, so people can look into that in a little bit more detail if they are interested in doing so. We know that research in neurodevelopmental care is continually evolving. How would you suggest healthcare professionals such as ourselves and colleagues may best stay up to date with the latest evidence and integrate this into their practice on the neonatal unit?
Yeah, it's a good question as well, because we don't have much time, do we, if we're working such long shifts. My favourite way to stay up to date with evidence for neonates is the Incubator podcast. So it's a podcast which is based in America, so it's 2 neonatologists out of Florida, and they go through all the latest evidence to do with neonates, and they do a journal club. And then they also interview people that are high up in the neonatology world or have done big research topics, and they break it down into really easy chunks to digest. So that's quite a good way of getting in some latest evidence whilst maybe you're like commuting to work, doing those long drives that we all have to do.
Wonderful. Thank you for sharing those resources with us and in an easily accessible format as well. So I'd like to talk a little bit more about that point of how, as healthcare professionals, we can integrate this into our practice. Is there any examples of good practice or any guidance that you might be able to share with us?
So I think one of the good examples of maybe like a QI initiative that has been going on of how we can try and improve developmental care, and it focuses on skin to skin, and that's the South West Cuddle Bundle, which is being implemented across all neonatal units, which includes like level 1, level 2 and our tertiary NICUs across the South West. And it's about trying to improve skin to skin different aspects of the baby's journey through the neonatal unit and when they go home, in all those ways that we've talked about, to reduce their stress, reduce stress with painful procedures, and to promote that maternal paternal infant bond as well, and to improve breastfeeding rates as well. So the project is part of like the South West Neonatal Network, but it's based on lots of evidence that's out there on the benefits of having skin to skin or cuddles. And we're using skin to skin and cuddles, the word, interchangeably, because parents feel that skin to skin is quite a medical term and cuddles is a much nicer term.
Absolutely.
And sometimes, you know, if a baby's having therapeutic cooling, they can't actually come out for skin to skin, but they can come out for a cuddle. So that's the interchangeable term.
No, thank you for defining that.
Yeah. Kangaroo Mother Care is also another term often used in the literature as well. And talking about literature, there's lots of literature out there. There's a study by Jefferies, and this shows that having skin to skin improves cardiorespiratory and temperature, makes it more stable. It can also improve sleep. Skin to skin can improve neurodevelopmental outcomes. It improves breastfeeding. It reduces pain responses, and it also has no detrimental effect on the stability of babies coming out for skin to skin who are on assisted ventilation, such as CPAP or high flow. And then interestingly, there's another study from Finland in 2020 which looked at babies coming out for skin to skin whilst they were ventilated, because I think this is a worry of getting babies out who are ventilated. You know, can their tube be dislodged? Do they become unstable? And it's about, so this study looked at the positive outcomes of having skin to skin whilst ventilated, and they found that it reduced the baby's PIP, so peak inspiratory pressure. It reduced their MAP, so mean airway pressure, compared to babies that were just kept in an incubator and didn't come out skin to skin. It also reduced their time on backup ventilation, so babies were more likely to spontaneously breathe. And this is crazy because these findings, you know, if you've got a baby that's not needing as much respiratory support on the ventilator, could they come off the ventilator sooner? Could that lead to lower levels of chronic lung disease? I mean, these are all like potential studies in the future, but it's a really interesting area of research. This study, they didn't find any adverse events such as tubes becoming dislodged or the baby deteriorating whilst out for having a cuddle. And it's about, recognising when you're on the NICU and maybe the parents are asked, can I have a cuddle with my baby? Or the nurse has asked, oh, can this baby come out for a cuddle? It's not just a nice thing to do. There are actually positive effects for that baby's development, but also that baby's potential chronic lung disease and need for ventilation. So there's all these other physiological reasons to benefit the baby for coming out for skin to skin.
Do you know if in that study by Lee in 2020 in Finland, did they look at the longer term outcome measures of chronic lung disease?
They didn't, no.
Okay.
But they thought that this could be an area for future research.
I see, okay.
It only came out 2020, so, hopefully there's a study, I don't know if there is, but...
Maybe there's some homework to see if there's any other evidence in this field.
Budding researcher out there that wants to look into it.
Amazing.
There's also another study by Charpak et al., which is 2022, and this is a study that I think started about 20 years ago, and they were looking at the neuroprotective effects of skin to skin, and they found that volumes of the main brain structures associated with intelligence, attention, memory and coordination were larger in babies that received Kangaroo Mother Care, aka skin to skin, compared to babies that didn't. So this is a neuroprotective effects that can last a lifetime, not just in the neonatal period.
Oh, wow. I guess a key takeaway would be that coming out for cuddles isn't just because it's a nice thing to do. But actually, this could have a positive and a long-term positive benefit for these babies.
And also not just the babies, but the parents as well. So there was a Cool Cuddle study, which some people in South West might have heard of or been involved with, where they looked at babies who have HIE who are undergoing therapeutic cooling. What are the benefits or not benefits of them coming out for a cuddle? And they found that ventilation, cardiorespiratory, neurophysiology and target temperatures all remained in normal ranges. So there wasn't a particular benefit to coming out based on their cardiorespiratory systems. However, they did find reduced postnatal depression and improved breastfeeding rates in babies that did come out for a cuddle. And I think the Cool Cuddle 2 study is going to be started in the near future.
Excellent. And I suppose the idea that even a baby undergoing therapeutic hypothermia were wanting to keep their physiological measures within set ranges, and there's clear guidelines on that. But the fact that we're still able to facilitate this developmentally supportive care whilst, as you say, maintaining those parameters, I guess is another thing that we could reassure parents.
Yeah,
because
definitely.
I think sometimes parents might want some support on how to balance what is best for babies' immediate medical outcome, but also their long-term outcome, but also their experience as parents on the unit. And as you say, the breastfeeding and bonding and postnatal depression and all those other benefits that we get from kind of this supportive care is really nice to think about.
Definitely, and that's part of what the South West Cuddle Bundle is trying to do, is because we appreciate that parents are probably just as anxious as the healthcare professionals, if not more, about getting their baby who's super sick to come out for a cuddle, and it's trying to support them as well. And the things that we can do is to talk to parents about their anxieties. A lot of parents that we've chatted to within this project have been a bit worried about getting the baby out, but also privacy. So if they're going to have skin to skin, making sure that it can be private, so maybe having some curtains around. And the Cuddle Bundle are producing some slings that parents can use, and they're going to be delivered to all the neonatal units. And we can teach parents how to use the sling so they can have skin to skin, but it's a bit more private rather than just popping the baby down their top. Also having mirrors available so that the parents can see their baby's face is a really lovely thing. And part of the Cuddle Bundle is about delivery room cuddles as well. So for babies that are stable, and with all babies coming out for cuddles, it's got to be that the baby is stable enough to come out. So it's a discussion with the consultants, the nursing team, the juniors, everyone that's around, to make sure that is this baby appropriate to come out? If they're not appropriate, could they have a hand hug? And then making sure that they come out safely. So medics, I feel like we always think maybe it's a nursing job, but we can get involved with it as well. So we can be there, especially if they're ventilated, we can hold the ET tube. We can definitely be around to help transition the baby from the incubator to the parent. And we developed some videos to teach medics and parents and nurses, but especially as I don't think we get much teaching on how to transfer babies out. So we can learn exactly like what position is the best way to get a baby out for a cuddle.
Oh, that's awesome. Is that accessible on the South West Cuddle Bundle page?
Yeah.
Lovely.
Maybe
so
we can put links on Peter.
We'll absolutely link to that in this episode as well. So we've spoken a little bit about some of the things that we can do as healthcare professionals to support developmental care, but also we recognise that this can be challenging because neonatal units are notoriously busy and time is something that's not in abundance. Have you got any strategies for overcoming some of these challenges or just making it part of normal practice?
Yeah, I mean, it can definitely be challenging. You've got sick babies, you're busy, and it's often the thing that's overlooked is developmental care. So it's definitely about the MDT. So what we found with the ward round is if we talked about can this baby come out for a cuddle on every single baby on the ward round, it was a really quick, easy way to then safety net and also think about babies coming out for a cuddle. And you could do that for all elements of developmental care as well. Ensuring quiet zones, ensuring safe zones, so if the baby's sleeping, not doing painful procedures then. And then it's just about education for us, for the staff, and also educating parents and having that family-centred approach. And just trying to think about things like we were talking about earlier about, can I do this heel prick whilst they're having skin to skin? I don't need to necessarily put them back into the incubator. And it's just, trying to create that environment that is supportive for neurodevelopmental care.
Another element to this is thinking about how we are able to communicate the developmental care which we're doing, and the same way as we might record how a baby's ventilator settings change over time. Is there a way in which we can keep track of the things that are being done to support the neurodevelopmental aspects of their care?
Formally, there's assessment tools like the Neonatal Individualized Developmental Care and Assessment Programme, the NIDCAP, and that could provide a structured way to evaluate a baby's developmental progress. Then there's the less formal ways, but just as equally important, such as the regular communication with parents about their baby's milestones and celebrating those baby's milestones as well. And then I think collaborating with if you're lucky to have an occupational therapist or speech therapist and other specialists such as the physiotherapist, doing the Bailey's assessments as well later. So it's a real MDT approach.
Thank you so much, Alicia, for giving us a deep dive into how we can be more cognizant of ensuring neurodevelopmental care is at the forefront of our minds in the neonatal unit. I wonder if you could offer some advice or perhaps some key takeaway points, especially for trainees like myself who might be earlier on in their journey of navigating the neonatal unit.
So things I've taken away, obviously I'm not an expert in developmental care, so speak to the occupational therapist, the physiotherapist, the nurses, the sisters, they probably have a huge wealth of knowledge about developmental care. So that's a good place to start. And then from that, I think just to remember the parents. And in the neonatal unit, we've got a really structured system of doing our ward rounds where we kind of present the baby. But actually maybe we should ask the parents first how they think their baby's doing, rather than going through all their problem list and then asking the nurse how the baby's doing. Let's start with the parents. How's your baby doing? That's a nice family integrated care way of getting parents involved in. And
again, something I think we do inherently in general paediatrics.
Yeah. Why do we do it differently? Nice. And like I said, with ward rounds, why don't we discuss developmental care as part of that ward round? Why don't we discuss, is this baby safe to have skin to skin? How can we make it safe for this baby to come out for skin to skin? Who's around? Who can hold the tube if they need to come out? And making sure we're educated about how to get babies safely out for skin to skin. And then other things is to acknowledge the baby's cues, like we were talking about, like the stop sign. That's an easy one to remember. And then positive touch to mitigate negative touch, and that includes hand hugs and skin to skin. And as we said, painful procedures. Do we need to put this baby back in the incubator? Could we do this heel prick whilst they're having skin to skin?
And that's a really practical, I guess, day-to-day implementation.
Yeah. And remembering it's not just a nice thing. There are so many positive benefits to the baby and to the parents, and to be an advocate. So if you want to, you can become a cuddle champion as part of the South West Cuddle Bundle, where you can have a badge.
Amazing.
But also just to advocate for babies to have skin to skin, but also advocate for their developmental care needs. So if it's really noisy, just asking, can we be a bit quieter, please? Or, if the lights are really bright, just turn them off, dim them down. So So little things like that, just to be a bit more aware of the developmental care needs of our preterm babies.
Excellent. Thank you so much. I think there's a lot of, as you say, key takeaway points that we can implement in our practice straight away. So thank you for coming along today, Alicia, and thank you for all your work with the South West Cuddle Bundle. We'll share links to a number of the different studies we've spoken about throughout this episode in the episode description. And if you have any questions or thoughts or would like to get involved, then please feel free to reach out via the South West Cuddle Bundle webpage.
Thank you very much. Thanks for having me.
Thank you. Bye-bye.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@peedshub.co.uk or via the PeedsHub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch.
Thanks for listening.